So a lot of people have asked me, why do I even need a radiographic guide? I really don't want to take an impression and send it to the lab. So the reason that we need a radiographic guide is because of all the varying densities in a cone beam scan, especially at the crown level and at the tissue level, you don't get a clear definition for us to get a surgical guide that's going to fit to our standards. And so that's why you need a radiographic guide, because when we do that dual technique, we're able to get a clear view of the supporting anatomy based on the radiographic guide's fit. And so that's why you need a radiographic guide. The times that you don't need a radiographic guide would be when the supporting anatomy can be defined in a different way or by different methods, or if you have a bone-supported guide. Cone beam does really well with imaging bone, and so, if you have a bone reduction guide, and you wouldn't need one with that. So those are the two main ways you wouldn't need a radiographic guide. If you build a radiographic guide for every single one of your cases, you're going to be able to get a surgical guide for every single one of your cases. There are cases where you don't have to build a radiographic guide, and you can actually get really, really accurate results from that. And when we start going into those alternative options, we start looking at the technology and terminology, DICOM and STL. And so DICOM is Digital Imaging Communications in Medicine, or the file extension is DCM. And what that is it's a universal file system. So if you're getting a medical CT, you're getting a cone beam, you're getting an CAD, you're getting a Newtome, a Kodak, whatever machine that you're getting or image that you're getting, they're all going to output or create a DCM or DICOM file. And that makes it so that software programmers or developers can make a program that will view that. So it's universal. Any of those machines create a DICOM. So if you have an imaging center, you request a DICOM and you'll be able to get it. The DICOM also is, you can see through the anatomy, so it allows you to navigate all the way through the anatomy. So it's like if you have a box and it's filled with something, you're able to see what it's filled with. You can slice through it and navigate all the way through that box. It's nice because, for treatment planning and things like that, but the only problem with that is you have a Hounsfield unit distortion. And the Hounsfield unit distortion is when you obtain a DICOM file, you can put it into a 3D mode, but you can build a 3D model out of it. But the 3D model is based on a threshold, and so you can move up and down the threshold, the Hounsfield unit threshold, to pick a certain density, and based on that is what your 3D is going to look like. So if it's set too high or it's set too low, then you're either going to be removing anatomy or you're going to be bringing stuff in that's not anatomy. It's just less dense air around it or soft tissue around it. So what I mean by all of that is, so here's a denture, and you can see here's gutta-percha markers, and they're raised up. You can see they're above the actual denture. And then there's like a little hole, it looks like, in the denture. And if we look at the actual denture, the gutta-percha markers are flush, they're not raised up, and there's no hole in the denture. And so this is important because when you're utilizing a technology where you're even the dual scan technology, when you're merging those together, if you don't pick the proper Hounsfield unit threshold, then, maybe it won't fit as tight or it will fit too loose. And so that's another variance as far as utilizing this type of technology. And if we've been doing this for years, so we're able to pick a good threshold to be able to, make them fit well. And actually, I would say about 85 to 90% of our cases are utilizing only DICOM data and only the DICOM technology. It's easy. As far as like sending us DICOM files, it's a quick process, and it doesn't take a lot of additional steps. And it's a good technology. We use it a lot. This is kind of an example of volumetric threshold. So this is a 3D scan, and we just put it in a 3D model and started moving the threshold, the Hounsfield unit threshold, up and down. And as we move it up and down, you can see anatomy start to disappear. You can see anatomy come back. And that's, those are the variances as far as utilizing the DICOM data. And the dual scan technique and using only DICOM is, that's what's clinically accurate. That's what everybody's been using. And so the other technology, when we're looking at alternatives away from DICOM, is STL or mesh. And this is used in stereolithography CAD software programs. And what mesh or what STL does is it's like a box again, except for there's nothing inside the box. It's just a surface. And so it's a bunch of little triangles that create a surface. And there's no threshold. When you scan it, that's the surface that you get, and you can't move it up and down a threshold level. And so it's very accurate. It's a great type of technology, but this requires utilizing models and shipping models, whereas utilizing DICOM, you can just upload, the DICOM files to our server. Where when you start to utilize the STL technology, that's when you would ship us your model and we would scan it for you. But it's very, very accurate. We've seen great results with that, and that's where we could eliminate or not eliminate completely, but that's where we don't have to utilize a radiographic guide. Is if you have a patient that doesn't have a lot of restorations, we can scan the patient and then send us the model, and we can do an STL of the model, merge those together, and then create a surgical guide that's going to be based off of that model and off of STL technology. And so it's going to be more accurate because you don't have those type of threshold levels that you're setting. So it's a good technology to use. We have a fair amount of people using it, but not that many because you can't use it on every case. And it does require shipping and things like that. So it takes a few more days for us to do the conversion and send it out, things like that. Another form of STL.
Can I stop you?
Sure.
Yeah. Okay. First of all, how can you recognize the correct threshold for a correct fit?
That's a great question. A lot of it is just experience in utilizing the technology, and it depends on the software program that you're using, how that's set up and designed. It's really just utilizing it and using it with experience over time. So.
Okay. Another question that came in: does Blue Sky Bio, Blue Sky Plan support STL?
Yeah, well, they don't. It doesn't import STL, but we're able to work with, we can take the STL and utilize it in the Blue Sky Bio. Like you couldn't open up your software and put STL in it, but we can take the STL and yes, definitely use Blue Sky Bio and treatment plan your case in Blue Sky Bio. Send us the final one, and then we can import the STL into that, and we can utilize that technology with Blue Sky Bio. And it's actually one of the very few software programs that allow us to do things like that. So, yeah, you can definitely use that.
Blue Sky Plan allows both techniques to be used, the dual scan and importation of the STL that Cindy was just describing. Okay, I think that's it for now.
Okay. So another type of STL is from digital impression systems, and so that's from, the iTero or COS or, and you can, if you have a digital impression machine or system in your office, you just request from, and I've talked to some of the companies, and they're pretty good at releasing the STL files. So, if you send us over the STL file, we are able to work with that as well in Blue Sky.